Hello students, welcome back to my channel. In this video, we will learn about cord prolapse. What is cord prolapse? Abnormal descent of the umbilical cord by the side of presenting part is called cord prolapse. What are the types of cord prolapse? The first one is occult prolapse, cord presentation, and the third one is cord prolapse. What is occult prolapse? The cord is placed by the side of the presenting part and is not felt by the fingers on internal examination. It could be seen on ultrasonography or during cesarean section. What is cord presentation? You can see the picture that the cord is slipped down below the presenting part and is felt lying inside the intact bag of membrane. The next one is cord prolapse. The cord is lying inside the vagina or outside the vulva following rupture of the membrane. That means the umbilical cord is seen outside the vagina or vulva. Incidence. The incidence of cord prolapse is about 1 in 300 deliveries. Etiology. What are the causes of cord prolapse? First one is malpresentation. The most common being transverse and bridge, especially with flexed legs, or it can be compound presentation. Second one is contracted pelvis. That means the diameter of the pelvis is less than the normal pelvis. The third one is prematurity. That means the baby is not mature or its age is less than 37 weeks. The fourth one is twins. Fifth one, hydramnios. Sixth one, placental factors, minor degree placenta previa with marginal insertion of the cord or long cord. The seventh one is iatrogenic, low rupture of the membranes, manual rotation of the head. How can we diagnose the cord prolapse? The occult prolapse is diagnosed. It is difficult to diagnose. The possibility should be suspected if there is persistence of variable declaration of fetal heart rate pattern detected on continuous electronic fetal monitoring. That means the normal fetal heart sound, that is 140 to 160 beats per minute, is decreased. The cord presentation. The diagnosis is made by feeling the pulsation of the cord through the intact membrane. The third one is diagnosed. That means cord prolapse is diagnosed. The cord is palpated directly by the fingers and its pulsation can be felt if the fetal is alive. Management. The management for cord presentation is, the aim is to preserve the membrane and to expedite the delivery. Once the diagnosis is made, no attempt should be made to replace the cord, as it is not only ineffective but the membranes inevitably ruptured, leading the prolapse of the cord. If immediate vaginal delivery is not possible or contraindicated, cesarean section is the best method of delivery. During the time of preparation, the patient for operative delivery, she is kept in exaggerated Sims position to minimize the cord compression. A rare occasion is a multipara with longitudinal lie having good uterine contraction with the cervix 3/4, that is the cervix is 7 to 8 cm dilated without any evidence of fetal distress. That means the fetal heart sound is normal. Watchful expectancy can be adopted till full dilation of the cervix, when the delivery can be completed by forceps or breech extraction. The management for cord prolapse. First, if the baby is living, cesarean section is the best option. Second, immediate safe vaginal delivery if possible. If the head is engaged, forceps delivery should be done. If the baby is in breech position, breech extraction by internal version should be done. The third one is immediate safe vaginal delivery if possible. Then first aid management is oxytocin infusion should be stopped. If any oxytocin infusion is started by any care provider, that should be stopped immediately. Then the bladder filled with 400 to 750 ml normal saline with Foley's catheter. Third, to leave the presenting part of the cord with gloved fingers introduced in the vagina, Trendelenburg or knee-chest position to replace the cord into the vagina. If the baby is dead, labor is allowed to proceed awaiting spontaneous delivery of the dead fetus. Thank you for listening.